Well, thank you to the AIUM for inviting me to attend this meeting, and it's been pretty interesting so far. I'm a practicing radiologist at the Washington, D.C. VA Medical Center, and I also am a researcher at the Food and Drug Administration, and I'm going to be giving the general position of the FDA on some of these safety issues, as well as my own personal clinical experience. So I'm going to skip that in the interest of time, but I do want to talk about what are the risk factors involved in any modality. Well, you have ionizing radiation exposure, you have other energy exposure, which would ultrasound would fall into that category. You have contrast material. We haven't talked a lot about contrast materials here today, but contrast materials are very important for proper imaging, especially with CT and to a lesser extent maybe with MR. And it would be very important also for ultrasound perhaps in the future. So there are some safety issues there. Delay in diagnostic testing is an important risk factor because obviously if you take too long to give the test and the patient has an acute problem, there's going to be some deleterious effects. And finally, diagnostic accuracy. So what about ionizing radiation? Safe levels, as you all know, safety levels for everything, whether it's food, anything that we do in this world, have been going down and down and down. So the safe level that you can pretty soon, in 100 years, you won't be able to take anything, eat anything, or do anything and be safe. But they've been trending downward over time. And these are a couple of examples of radiation-induced injury. Here, there's a couple of attempts at a TIPS. This is done under fluoroscopy, and you can see there's a large radiation-induced ulcer in the patient's back. And then this was done with CT. A 60-year-old after intervention for a stroke, they were trying to take care of some of the vessels. They've been going down. The cumulative dose, interestingly, which is what we were trying to use to decide, we would report the cumulative dose of a patient, and then we'd say, should they have another CT or not? It turns out the opposite effect occurs from what you might expect. You'd say in somebody with a high cumulative dose, you shouldn't give another CT. Well, it turns out their actual risk is lower once they've had a lot of CTs if you give another one. So the incremental risk to them is lower probably because their other risks are already so high. So you can use it for assessing population risk, but you can't use it to make individual patient care decisions. So we haven't come to a real good conclusion about how to handle how people should order tests, except that we should always try to prefer the test that gives less radiation, because to the population as a whole, that's going to be very important in reducing risks of injuries. And finally, for radiation, of course, overuse can easily lead to injury, as shown here. And what does this mean in terms of the FDA? The FDA considers radiation a very high risk situation. They do not consider ultrasound even in the same risk category. It's not even considered on the radar scope in terms of risk. So a lot of the effort in the FDA is now in producing safer devices that emit radiation and reducing the radiation dose. So what about dose? Evidence for radiation-induced cancers above 6 rads for us old-timers, 60 millisieverts for the younger folks, were both basically based on A-bomb studies and the Chernobyl release of radiation. So there's one good effect of the Chernobyl disaster. So as I mentioned, incremental risk declines in patients with a higher cumulative dose. And the evidence, as was mentioned earlier, supports most strongly a linear no-threshold model according to the National Academy of Sciences. So what that means is that even small doses are going to incrementally increase your risk for cancer a tiny amount. There's no threshold below which you can stay and be completely safe. And of course, radiation is more injurious to young patients. And this is a plot that shows the risk. This is the lifetime risk of radiation-induced cancer per 1,000 millisieverts, pediatric age group, and you can see it declines. Obviously, the risk here is pretty low because the person's dead already. So a lot of that is the fact that they don't have as much time to develop a cancer after they've received the radiation. But another way of looking at that is that small incremental dose of radiation increases their risk. It just takes longer if it's smaller. So patients are the most sensitive patients are the pediatric patients, and we see the effects of small doses of radiation in the pediatric patients so they have a long enough time to show those effects. So the message is keep ionizing radiation exposure to a minimum. And ALARA has already been mentioned by Fred with respect to ultrasound, but it holds for all modalities. And so the ALARA principle is expected to be adhered to for all modalities. And those of us who do a lot of CT know that sometimes it's used, sometimes it isn't. So we're looking for ways at the FDA to reduce that using iterative reconstruction, other methods to better control the amount of radiation given. One way you could do it is by interleaving CT with other modalities for follow-up, and I think that was also alluded to in terms of kidney stones. Maybe the first study is a CT, and after that you can follow them with ultrasound. Or if you're doing a cancer study, you do every third with CT just to get an anchor point, and you can follow in between with ultrasound. And then finally, limiting exposure during examinations. So what about non-ionizing radiation exposure? As Fred mentioned, there are thermal effects and there are non-thermal effects. Now, the thermal effects apply to both MRI and ultrasound, and they're due to deposition of radiofrequency energy, which causes heating, both for electromagnetic waves and for acoustical waves. The non-thermal effects, primarily cavitation, as he mentioned. For high power levels, these effects can be significant and serious. So I'm going to give you a little bit of a comparison. Let's take a couple of examples. Electromagnetic radiofrequency energy, microwave oven. And I don't know if anybody's stuck their hand into a microwave and tried to turn it on to see how hot it gets fast. Usually you can't do it because it's interlocked to the door. But another example is the RF tumor ablation device. And this is an example of an RF ablation device this is a piece of a liver. They're sticking it into a tumor, and it shows the area where it's going to be ablating. Now, if one of these little tines, they start all together, and when you deploy them, they all unfold like an umbrella. One frequent complication is one of these tines goes somewhere that you don't want it to go, for instance, into an adjacent bowel loop, and then you get a perforation, which is clearly a risk factor. The RF tumor ablation devices put out quite a bit of energy in a small area. What about acoustic energy? Well, physical therapy units, which was mentioned by Fred, produce mild heating and are very helpful for relieving discomfort in muscles. Higher intensity ultrasound, HIFU treatments, these are a couple of examples of HIFU devices, and they produce a very, very intense heating effect very locally. And finally, we have the lithotripsy devices, which produce a shock wave, which is more of a mechanical effect. So what about intensity level comparisons? So for electromagnetic waves, we have the 800-watt microwave oven, which produces the SAR as a way of measuring radiofrequency energy from electromagnetic waves, the heating effect in tissues. For an 800-watt microwave, we get about 112 watts per kilogram deposition of energy. The FDA whole body limit for an MRI scanner is 4. So you can see that's a significant fraction of 112. That's 5–6%, 4% or so of what a microwave would do, and that certainly wouldn't be allowed in a person. For ultrasound devices, the HIFU, on the other hand, puts out 1,000 watts per square centimeter, whereas a diagnostic ultrasound machine is typically less than 1 watt per square centimeter. And if you look at the pressure, which is more of a mechanical effect, this is the compressional wave pressure, 10 megapascals for diagnostic ultrasound and 100 megapascals for lithotripsy. So diagnostic ultrasound is actually, compared to some treatment devices, way less than what you see for MR versus a microwave. So exposure guidelines would be the exposure levels from diagnostic ultrasound are extremely low, and no significant adverse clinical effects have been observed over the 50 years or so that we've been doing ultrasound. But these levels have been gradually increasing, which has prompted a few recent safety statements from both AIUM and the World Federations, specifically related to fetal Doppler, where people can use M-mode to look for fetal heart motion. A lot of people, just because it's easy and it's quick, they use Doppler. And that can produce significant problems because what you rely on in tissue is the blood circulation to carry away heat from tissues that are being heated, but close to bone or in tissues that don't have good circulation or very early in gestation, the heat dissipation mechanisms are not as efficient, so there's a greater potential for risk. And again, all diagnostic systems should be used keeping the exposure to the minimum necessary for diagnosis, in other words, the ALARA principle. So what about contrast agent safety? X-ray and CT, let's look at those. Iodinated contrast greatly improve the diagnostic capability of both X-ray and CT. Here's an example of a patient with liver metastases from colon carcinoma, including one to the kidney, which you can't see on the non-contrast CT. Now, ultrasound, to its credit, could probably see this metastasis pretty well without a contrast agent. The problem, of course, with contrast agents is they're relatively toxic, and they're contraindicated in patients if their kidney function is less than 50% of normal. And where's that a problem? Well, at the VA where I work, it's a big problem because about half of our patients have less than 50% kidney function because diabetes is rampant and it causes a lot of kidney injury. So we don't really gain the advantages using CT that we could if we could use the contrast agent. So therefore, ultrasound should become more important. Yet, what I see time and time again is I'm ordering a CT without contrast when everybody knows it's going to show nothing. And it's not even going to be conclusive in this just because they're more comfortable with it. So what about contrast agent for MRI? The gadolinium chelates greatly increase the usefulness of MRI. It's not quite as critical as it is for CT, but it can't be used in patients with decreased function because of a problem called nephrogenic systemic fibrosis, which has a fatality rate of 20 to 48%. And if you, the incidence rate is pretty high if you do it in somebody with less than 50% kidney function. So there's a lot of patients that MR can't be used optimally for as well. Ultrasound contrast agents. They're typically encapsulated microbubbles to increase backscatter. They're not generally used in the USA, but they're massively used worldwide. And we're the only country that doesn't use them, and it's a primarily reimbursement issue in this country. The contrast reaction rate is really low. In fact, there was a recent FDA panel was convened, and the argument was they couldn't calculate it accurately because the incidence was so low. But it's typically around 1 in 10,000 patients. In other words, and compared to the incidence of reactions for iodinated agents, which is between 1 and 12%, and gadolinium agents, which is between 0.1 and 2.4%, it's 100 times less toxic for ultrasound contrast agents. So it's really important to realize that ultrasound is way safer from a radiation exposure standpoint. It's also way safer even if you use contrast agents, way safer. So I want to point out natural contrast agents because this is really important. People say ultrasound doesn't have good image quality, and the reality is ultrasound is complementary. In a large fat patient where you have a lot of fat to give a lot of contrast to the CT, you can get away without using contrast in a lot of situations. Ultrasound in a fat patient may not do as well because of aberrations in the beam, but in a thin patient where CT doesn't perform well at all, ultrasound does very well. So in pediatric patients who are, at least in the past, were very thin and small, ultrasound would definitely be the preferred method of choice because it images so well and CT doesn't image so well. And also air blocks the ultrasound beam, so you, in patients with a lot of gas, CT might be better. So CT and ultrasound are complementary. CT does better in older, heavier patients. Ultrasound does better in younger, slender patients. So another significant risk factor is exam access time. Getting exam results promptly is really an important safety factor, especially for emergent issues. Typical examples might be a ruptured appendix, ischemia due to torsion, acute hemorrhage, venous thrombosis, and pulmonary embolus. These delays not only can injure the patient, but they disrupt the patient management. If you have the attending there and the entire entourage and they can get a result right away, they prefer that because they can make a decision regarding management right away, whereas this test is going to be 2 hours, this test is 6 hours, and everybody's all gone out of the house, and it's hard to get a definitive decision on how to manage inpatients. CT exam time used to be much longer or equal to ultrasound. Now it's way shorter. So there's a big advantage for CT. And it's much more readily available, and that's probably because we've made it more available, because there's been a lot of demand for it. But oftentimes, a lot of places don't have an ultrasound tech in-house, and so you have to call them from home. That adds an hour. And then by the time they get the patient transported to the ultrasound suite, another half hour to 45 minutes, where the CT in the emergency room is done in 45 seconds. What about modality accuracy, CT versus ultrasound? CT has been long perceived to have a broader applicability and higher accuracy. And this is definitely true in some situations, such as kidney stone detection. But it's not true in others, especially for CT without contrast. Nobody would think that CT is anywhere comparable to ultrasound for detection of thyroid nodules. Breast masses, CT has been a miserable failure. Even with the advent of new specially dedicated breast CT scanners, the jury is still out on how well it'll do on breast masses. Testicular and ovarian torsion, small soft tissue masses, ultrasound has always been dominant. Diagnostic errors in either direction can lead to a delay in diagnosis, incorrect treatment, or extra tests and costs. Well, what about the causes of decreased ultrasound accuracy? One big one is variation in sonographer training. This is important because in traditional ultrasound, the sonographer has to detect abnormalities, unlike the CT operator who simply positions the patient and presses a button. Part of it is failure on the part of us clinicians who do ultrasound to aggressively prepare patients for ultrasound. Every CT patient is aggressively prepped. They have tons of oral contrast given. It's fairly strict, and how they start the exam, how they proceed through the exam is very strict as well. So these are a couple of things that we've gotten lax on perhaps, and we could improve. Finally, failure to incorporate volume scanning. That was mentioned by Beryl early on. And if you use volume scanning, you end up with a series of images that the sonographer doesn't necessarily have to interpret. You can look through the images and find the abnormalities as an interpreter yourself. And so all these problems, these causes of decreased ultrasound accuracy can potentially be fixed. It just requires the will and the drive to do it. It happens in some places where they don't have the option to do CT or MR. In this country, we've been a little lax about that. So what about choosing modality? Does the FDA have a role? For the use of diagnostic tools already cleared or approved and marketed, choice of a modality is entirely the province of medicine. Congress was very specific about not giving the FDA authority to regulate medicine, the practice of medicine. So that is strictly off limits for us, and we cannot look at that. Another thing we can't look at is cost. We were specifically prohibited by the law to look at the cost of a modality. So when we say something is safe and effective, we are not allowed to look at any cost information about that. That's something that you, as the users, as the payers, as the medical community, have to make that hard decision on. We don't have any direct authority over the use of these legally marketed devices. But we do have some indirect influence because we're very strict about making sure that the companies properly list their indications for use. And the indications for use give you a rough guideline of what we feel are the appropriate indications for the device, the ones that have been proven scientifically to us in their submission. So in conclusion, you have to recognize that ultrasound subjects patients to a lower exposure of potentially injurious energy than does CT or radiography. Contrast agent risk is way lower for ultrasound agents than it is for MRI or CT contrast agents. And these are really helpful and sometimes necessary for these modalities to be superior. But for the clinicians and for this group here, we have to identify carefully what situations will ultrasound outperform CT and vice versa, and make sure the patients are referred accordingly. And finally, we really do need to implement some methods for improving ultrasound accuracy across the nation, in this country especially. Thank you.